let me take you through a new area of a fetal echo. This talk is meant for persons, adult cardiologists, those who want to do a fetal echo or are doing or beginning to do a fetal echo, what they should know about it. But that certainly this can be viewed by people, those radiologists or sonologists, those who want to start fetal echo. I just want to tell you what are the differences between adult echo and a fetal echo. Both are entirely different fields. If you don't believe me, go through this entire video and I'll step by step tell you the differences between adult and fetal echo and give you cautions where we need to be careful. I think it's a good idea to subscribe so that when I'm going to post next lectures, you will be notified. Wonderfully said that, as a cardiologist, this is a good cartoon. To give you an example, now if the cardiologist says that I can't swim, but it doesn't really matter because the water is shallow here only. That's true for adult echo, but certainly you are going to go into deep waters when you are thinking about doing fetal echo. So this is what my entire talk is going to be. What are the differences? And I have divided these things in a different categories. And let me start with an equipment first. You look at the image here on the right side. This is on a cardiology based equipment. Okay. So cardiology based equipments, we love speckle. We don't reduce speckle. Now there is in the less dynamic range, that means the contrast is more. You do not have number of gray scale zones and it is not as smooth as we would expect it to be. But the advantage here we have is that we are good in color Doppler and a frame rate during color Doppler, but we are not as good in 2D. In a radiology based equipment, there are ways of reducing speckle, which I'm going to tell you in the subsequent slide. The dynamic range is more so that you can see more shades of gray and it gives you a smoother image by certain techniques what they use. But they are not good in color Doppler because frame rate is actually affected by all those speckle reducing techniques which they are being used. So we have to strike a balance between the two, and I am going to tell you what is the speckle reduction technique. Tissue harmonic also reduces speckle, but we use that in cardiology machines as well. And then you have a speckle reduction techniques which I am going to share with you. One of them is a compound imaging. And what is compound imaging? We scan, the scan lines are perpendicular, then it is a different angle, then the third is another different angle. So once we scan the same frame in a different angles, the speckles are not the same, but tissue remains the same. Tissue doesn't change. So if you add up or do a subtraction, what happens is that speckles are different in different frames, right? In the different scan lines, but tissue is the same. So tissue is highlighted and speckle is nullified. So that is how you see a very smooth, nice, but this obviously comes with the cost of reducing frame rate because you are scanning more than what you would have scanned otherwise. Other ways of maximizing frame rate as the structure of the heart is too small is to reduce the depth and the width, or you zoom the thing so that the area scanned is small and the frame rate is high. Keep looking at the frame rate on your equipment wherever that's displayed and keep the frame rate high when you are viewing a fetal echo. And another thing which I want to tell you is a good idea to have a 2D and a color Doppler side by side while you're doing fetal echo. You don't lose on the frame rate at all, but the advantage is you know where the color is emerging from. Now, if the color here is there and there is something called balance which I am going to discuss, color is overriding the information of 2D. Right, the 2D is not seen here. You don't see the tricuspid valve here. This is fetal echo with Epstein anomaly, and you see the tricuspid valve here. And if you have a side by side 2D and color, you know the where the color is originating from, and you know the tricuspid valve. So it's a good idea without losing frame rate, without losing anything. So it's always a good idea to have a 2D along with a color Doppler. Something interesting, something which is well less known, and many of us do not use it and even know it, and that is balance or priority told in certain equipments. What is balance? Balance is that once you've acquired data on a color Doppler and when you are going to display it, so which one becomes more transparent and which one becomes more solid, or which one should be given priority in a certain area, color Doppler or a 2D. So if you give a preference to 2D, the 2D will kind of smudge the color Doppler data, and in case you give importance to a color Doppler, that would override information on a 2D. So that is an advantage. You want more of a color Doppler rather than 2D in fetal echo. And where do you see balance? Once you put the color Doppler on, you see this color Doppler bar, and just adjacent to the color Doppler bar you get a 2D bar, and this marker here tells you the balance. If you move the marker down, it would tell you that you are giving more balance or more priority to 2D. If you move it up, that means you are giving less priority to 2D. So please give less priority to 2D and more priority to the color Doppler so that you can see small color Doppler changes easily. And I'll give you an example. That's an example where the priority is kind of a midway and you don't see too much of filling, but you get 2D, which is very nicely displayed, and you don't see pulmonary veins too well. But when you increase the priority, then you give priority to the color information, which was not seen here because it was overlapped by the 2D, now starts getting better. So this is the balance. So keep the balance as high as possible so that you see color overriding the 2D information. In this lung area, you don't need 2D information. You need a color Doppler information. Another example. That's a patient with a ventricular septal defect on a fetal echo. This is about 18 weeks of gestation. And you see this is a mid-muscular VST with a color Doppler flow across it. And this is the priority, right, given to the 2D. We are not giving any priority, much priority to 2D. But if you start giving more priority to the 2D information is overwriting on the color Doppler. So you don't see color Doppler, you see more of the 2D, right? You would miss a VST in case. So just open up whenever you open your color Doppler box, and please see on the side that this is the color Doppler bar and this is the 2D bar, which gives you an idea about the balance. There are more ways of improving color Doppler sensitivity and improving the fill, but I don't think so. I would go into detail. Maybe I'll post another talk on how to optimize an equipment for either color Doppler or adult cardiology or a fetal echo or a peripheral vascular Doppler. So I would post a separate lecture on that. But you should know what all things are there. You can increase the ensemble, the line density and packet size. All these actually tend to improve the sensitivity, obviously at the cost of the frame rate. If you increase all these things, the frame rate is going to drop. And how are you going to improve the frame rate? Just make the box small as possible. New thing what we use in fetal echo very frequently and radiology is a power Doppler. Now, what we do in a color Doppler, the color Doppler visualization depends upon what? It depends upon the velocity. Higher the velocity, you would see a better color on your frame. Correct? But power Doppler is not dependent on velocity, it's dependent upon amplitude. And amplitude, for example, there are RBCs which are traveling very slowly in the vein, but the number of RBCs are same as compared to the RBCs traveling very fast in an artery, but the number of RBCs are same. So if you are trying to find out what are the number of RBCs, which is an amplitude, how many people or how many RBCs are there, that is an amplitude. and you will be able to pick up a small or sluggish or slow flows in the vein. And that's a circle of Willis where the velocities are small. So this comes very handy and good in fetal echocardiography. So again, number of RBCs, let's say the single singer is singing, but the frequency is the same. So that's the frequency, and this is the frequency a single singer is singing. And then there are multiple singers, like I told you, there are number of RBCs which are traveling, giving you that same frequency, but the amplitude is more. Now, if you base yourself on the frequency, you would miss. But if you base your technique on amplitude, even a low or slow moving blood would give you good signals. So that's very useful in fetal echo. The first and the most important thing is size. That is what is actually limiting our visualization. And in case you can see the comparison, fetal heart at about 18 to 20 weeks is size of an almond, and weighs about 200 to 50 grams in an adult heart. And this is a bovine heart for comparison with the fetal heart. And you can see the size difference. And size difference matters reason because our resolution of equipment is limited, and if they have a smaller size, our resolution is going to be more impactful. And bit about resolution, you have axial resolution, that is along the side of the beam, and that is the best resolution. You can differentiate 2 points better on an axial resolution than on the lateral resolution, and the worst one is azimuthal or thickness resolution. This has a very, very important bearing on fetal echo, and subsequent slides are going to show you that. For example, you think that the image what you see on color Doppler screen or your equipment screen is a razor thin image, but this is like something like an old 4-slice CT machine. The structure what you're seeing, it's a thick slice what you see on your monitor. Okay, thick slice means that it overlaps data from a very large thick slice, so that the data is from the behind and from the front are overwritten on each other, and you see this. So in here you see this is an aorta coming out of an LVOT view, but because, and then you see another small blue color here, and this is nothing but pulmonary artery data being overwritten on the aorta because of the large thickness. So we must, even if the structures here on the monitor look side by side, but actually they are lying anterior and posterior, and this is because of the thickness. You see the entire thickness here, the data are overwritten. So this is how you see. And similarly on this is a fetal echo of LVOT and RVOT seeing together, and you think that aorta or pulmonary artery are merged together or coming out of each other, but that's not true. They, because of the problem with the thickness of the ultrasound beam, the resolution, azimuthal resolution, they are seeing in the same frame. Because of all this lateral, azimuthal and axial resolution problems, many a times you miss an abnormality just because the angle of the heart is different. I give you an example, very nice example which we recorded. Now if you see here, this is heart in the lateral 4-chamber view, and things are looking okay. But the moment if you see an apical 4-chamber view, you see there is a large ventricular septal inlet defect, and there is a large ostium primum defect, and that actually makes it a common AV canal defect. The entire scenario has changed. Now you have a common AV canal defect, the counseling, the outcome, everything is going to be different. The association with the trisomy 21, it all are going to be a new dimension which is going to open. So for example, in a perimembranous area is a fibrous tissue, and the resolution is a bit of an issue problem there. And how the resolution affects there, you see this is a perimembranous area. You're not sure whether there is a membrane there or there is a defect. Very challenging, very difficult. And then in the next video, you see a dropout, a very clear dropout. Obviously this dropout cannot be a VSD. This is an aortic valve, and VSD cannot be above the aortic valve. This is actually a drop off of the sinus of Valsalva. So these dropouts are a big Achilles heel for person who is doing a fetal echo. The reason being that we are limited by the resolution of the current equipments available in the market. Now, same that if you see on the VSD, how do you diagnose VSD? You have to note if there is a bidirectional flow or if there is a phasic flow in the VSD, which I think I would touch upon in my next slide. So you are using some indirect or different signs which you would have not used in adult echo to overcome this limitation of resolution. And VSD is diagnosed by a bidirectional flow with more of a confidence. So if you have a bidirectional flow, because of the pressure in both chambers are fine, and that's what you see. And then let's come to the next. So because there are resolution problems, you are not dependent upon the direct signs, you find some indirect signs to prove your point. So I'll give you an example. TAPVC way back in 2005, and prior to that, the incidence of pickup of TAPVC was just 2%. We were missing more than 90% of the patients, and what we would problem was that the resolution was poor, and we missed many of the patients with a TAPVC because we were looking for direct signs that the pulmonary veins are not opening into the left atrium, they are opening into the posterior chamber, and this direct sign may not be very clear. Now look at here, what are we depending upon? Now this is a patient of a TAPVC. You see this one pulmonary vein coming here, and it is joining the posterior chamber, and it might, in case you don't see this membrane, okay, it would appear that the pulmonary vein is opening into the left atrium. Okay, so now the pulmonary vein, now this entire diagnosis of TAPVC is dependent on visualization of this membrane, and this is too thin, and because of the resolution issue, it may not be seen. So you miss. So now we use indirect signs of TAPVC. I'm going to share with you a couple of indirect signs of TAPVC. What are the indirect signs of TAPVC? Normally, this is the normal for comparison, and this is where you see the distance between aorta on cross section and the LA wall is increased. Why it is increased? Because one, the pulmonary veins anchor the heart behind posteriorly, and there's nothing to anchor the heart. Secondly, there is a posterior chamber here which can be seen as a twig sign. So we develop new signs of TAPVC which are indirect signs, because direct signs were not very reliable because of the issue of the resolution. So I'm going to show you an example of indirect signs. The first example is that the left atrium is kind of rounded. In normal, the left atrium is box-like because it's anchored by the pulmonary veins, and it is squarish. Now it becomes rounded as no vein opens into the left atrium. And then the second one is a twig sign. You see small twig behind the left atrium, and this is the posterior chamber, and that's how you see it. So we use these two indirect signs to say that this is TAPVC. We described another sign of a Coumadin ridge. We know Coumadin ridge in adult cardiology, and Coumadin ridge is a ridge between the left atrial appendage and the left upper pulmonary vein, and this ridge is called Coumadin because this was on transesophageal echo confused like a thrombus, and Coumadin was started, and then the name for this is Coumadin ridge. And if we see Coumadin ridge here, and what is the requirement for Coumadin ridge to form? Left upper pulmonary vein and left atrium invaginates like this and creates this kind of a ledge. So in case the pulmonary vein does not enter the left atrium, you would not find the ridge. And ridge is very good and easily visualized on a 2D of a 4-chamber view. You see this ridge, and if this ridge is absent, that means the pulmonary vein is, this pulmonary vein is not entering into the left atrium, right? And in case the ridge is present, it rules out TAPVC because at least one pulmonary vein is entering into the left atrium. So this can be used as a